What's up, CardioNerds? This is Dan and Amit, and we can't thank you enough for tuning into CardioNerds. Your support as listeners since December of 2019 means the world to us.
We are honored to announce the birth of a new podcast, CardioNerds Cath Masters, designed to democratize interventional cardiology education. This is intended for an advanced audience with a strong technical foundation. At Cath Masters, we aim to deliver high-quality, evidence-based, and experience-driven procedural education across all segments of interventional cardiology. If this resonates with you, we invite you to check out Cath Masters on your favorite podcast app. As you have done with CardioNerds, please do rate and subscribe to the show to help others seeking interventional cardiology education also find Cath Masters.
The breadth and depth of CardioNerds education have been possible because of all our collaborators within the CardioNerds Academy, Healy Honor Roll and Fellowship programs, and several cardiovascular professional societies. We want to take a moment to thank them all for supporting our mission to democratize cardiovascular education. And of course, thank you for tuning in.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey, cardio nerds. Welcome back to another episode. Today's episode will focus on coronary artery disease. Coronary artery disease remains the leading cause of death in the United States, and chronic coronary artery disease, although sometimes in the shadows of its acute version, remains significantly impactful for patients, providers, and healthcare systems. My name is Natalie Marrero, incoming cardiology fellow at the University of Miami Jackson Health System and CardioNerds Academy chief for House Taussig. I'm joined today by two incredible co-hosts, Drs. Rafael Toro and Ritika Tuli.
Hey everyone, I'm Rafael Toro, third-year internal medicine resident at Rutgers University and current House Taussig fellow in the CardioNerds Academy. Today, we are venturing deep into the world of chronic coronary artery disease, specifically the role of non-invasive modalities in the evaluation and stratification.
And I'm Ritika Tuli, a second-year cardiology fellow at Allegheny General Hospital, and I'm especially excited for today's episode because it sits at the intersection of two things I absolutely love: clinical reasoning and cutting-edge imaging. Over the past decade, the tools we have in our hands to non-invasively evaluate chronic coronary artery disease has expanded enormously, from stress echocardiography to CT, angiography to stress PET and cardiac MRI. Knowing which test to order and why is pivotal in clinical practice.
And to help us navigate the chronic coronary artery disease landscape, we are truly honored to welcome our expert guest, Dr. Panithaya Chareonthaitawee. Dr. Chareonthaitawee is a professor of medicine at the Mayo Clinic College of Medicine. She received her medical degree from Northwestern University and then moved to Rochester, Minnesota, where she completed her internal medicine residency and cardiovascular medicine and nuclear cardiology fellowships. Additionally, she was an advanced fellow in cardiac PET imaging at the Imperial College School of Medicine in London. Currently, Dr. Chareonthaitawee is the director of the Mayo Clinic Nuclear Cardiology Laboratory in Rochester, Minnesota. She has just stepped down as the education chair for the Department of Cardiovascular Medicine and also from her role as the Department Diversity Co-Chair. She is a nationally and internationally recognized leader in nuclear cardiology and cardiac PET imaging and is the immediate past president of the American Society of Nuclear Cardiology, and currently serves as the deputy editor of the Journal of Nuclear Cardiology. Dr. Chareonthaitawee, thank you so much for joining us. We are very excited to have you join us today at the CardioNerds Clinic and to learn from you about this topic.
Thank you so much, Natalie, for that very kind introduction. And I'm really delighted to be here with all of you and to join the CardioNerds Clinic today. I've long admired the way CardioNerds makes complex cardiovascular topics so approachable, clinically grounded, and lots of fun. So it's a real great pleasure for me to be with you today. So the topic today is also close to my heart because chronic coronary artery disease is something we all encounter every day. And yet, the evaluation can be surprisingly nuanced. We now have many excellent imaging tools available, but the challenge is choosing the right test for the right patient and for the right clinical question. So I'm looking forward to discussing that with you through the great cases you put together today.
We're very glad to have you here today. The CardioNerds Coronary Artery Disease Clinic is quite busy today, so let's get started with our first patient, Mr. Occlusion. He is a 58-year-old male with past medical history of hypertension, olmesartan, and amlodipine, type 2 diabetes managed with metformin, and ankylosing spondylitis on NSAIDs, who was referred by his primary care doctor for evaluation of chest discomfort. He describes episodes of pressure-like chest pain occurring when he walks his dog and sometimes after eating spicy food. He describes his pain as a heaviness in the middle of chest with no radiation. He denies any pain at rest, nocturnal symptoms, or associated diaphoresis or nausea. He denies any family history of cardiac disease. His most recent labs showed an A1C of 7.4%, an LDL of 145, HDL of 38, triglycerides of 160, an LPA that was less than 14, and a high sensitivity CRP of 1.2. The physical exam is relevant for obesity with a BMI of 31.5. Dr. Chareonthaitawee, this is a patient whom many of us have frequently encountered in the clinic. Someone with chest discomfort that is at times exertional, but also related to other activities, with a handful of risk factors and a worried primary care doctor. Before we even talk about diagnostic testing, let's start at the beginning. How do you define chronic coronary artery disease? And can you please walk us through the underlying pathophysiology of it?
Of course, this is a great place to start because the terminology has evolved. We used to think about stable ischemic heart disease or stable coronary artery disease, but I think chronic coronary disease is a better term because the biology is perhaps not truly stable. Coronary atherosclerosis, as many of you know, is a dynamic process. Plaque can develop, progress, regress with therapy, rupture, heal, and it can coexist with endothelial and microvascular dysfunction. And clinically, chronic coronary artery disease is an umbrella term. It includes patients with stable angina, patients with known or non-obstructive or non-obstructive coronary atherosclerosis, patients who have had prior MI or revascularization and are now in a chronic phase, and patients who have ischemic symptoms without obstructive epicardial disease. Pathophysiologically, the classic model is epicardial coronary atherosclerosis, causing fixed or diffuse narrowing. During exercise or emotional stress, myocardial oxygen demand rises, but coronary blood flow cannot increase enough, leading to a supply-demand mismatch and ischemia. But many patients have symptoms from more than just a focal stenosis. There can be vasospasm and coronary microvascular dysfunction that can also limit flow and produce real ischemic symptoms. And so that brings us to the ischemic cascade. Abnormal perfusion and reduced coronary flow reserve usually occur before wall motion abnormalities, ECG changes, or symptoms. And that's why different imaging tests can detect different parts of the disease process and also may have different diagnostic performance. So getting back to Mr. Occlusion, I would not be falsely reassured by the fact that some of his symptoms sound somewhat mixed. The exertional heaviness definitely gets my attention, and his diabetes, hypertension, and dyslipidemia all increase the likelihood of coronary artery disease. We also know that patients with diabetes often have less classic ischemic symptoms and often present with dyspnea, fatigue, reduced exercise tolerance, indigestion, or simply a decline in functional capacity. Diabetes also often travels with a broader cardiometabolic phenotype, where we may see not only focal epicardial coronary artery disease, but also diffuse atherosclerosis, coronary microvascular dysfunction, impaired coronary flow reserve, and elevated filling pressures. So exertional dyspnea in this population can be an anginal equivalent, or it could be a manifestation of HFpEF or both. And so that's why chronic coronary disease should not be reduced to just a simple question of, is there one severe stenosis? it's really a spectrum of coronary atherosclerosis, ischemia, vascular dysfunction, symptoms, and risk.
Thank you for that wonderful explanation. For me in particular, it's helpful to think of chronic coronary disease as a dynamic process and think of it as an umbrella term that can include anything from stable angina to non-obstructive disease to patients with a prior MI or revascularization, and even patients that have these ischemic symptoms and don't have any obstructive disease. And I really liked the explanation that you provided of visualizing it as a supply and demand problem. And that can come from either a focal stenosis or vasospasm. So it was very helpful to hear how you think about chronic coronary disease. Now that we understand what chronic coronary disease is and how it can present, let's talk about what to do with a patient like Mr. Occlusion before we think about ordering an imaging test. Dr. Chareonthaitawee, the 2021 ACC/AHA chest pain guidelines described a structured approach to thinking about chest pain and determining the likelihood that that chest pain is of cardiac etiology. Can you walk our listeners through the guidelines classification of chest pain into cardiac, probable cardiac, and non-cardiac pain, explaining the concept of pretest probability, why it matters, and how we can use it clinically?
Absolutely. So before we order a test, we have to slow down and ask ourselves, how likely is it that this patient's symptoms are related to myocardial ischemia or coronary disease? And that starts with a careful history. And the 2021 chest pain guideline encourages us to move away from the term atypical chest pain. And this has been very tough for me because we've used this term for maybe 20, 30 years. And this term, atypical chest pain, can be misinterpreted as benign or non-cardiac. And so instead, we should try to describe symptoms as cardiac, possibly cardiac, and sometimes probably cardiac, or non-cardiac. And so cardiac features include central or substernal chest pressure, heaviness, tightness, or squeezing sensation, especially if it's brought on by exertion or emotional stress and relief with rest. But patients don't always say pain, so they may describe some of these symptoms as some type of discomfort. And they may also have anginal equivalents such as dyspnea, fatigue, diaphoresis, indigestion, or reduced exercise tolerance. And all of this is especially important in women and in patients with diabetes who may have not classic symptoms. And very important also for Bayes' theorem. And Bayes' theorem is an important concept in diagnostic testing. It reminds us that post-test likelihood of disease depends on both the patient's pre-test probability and the performance of the test. And because no test is perfect, we have to estimate the likelihood of disease before we interpret the test result. And in practice, we estimate the pre-test probability or clinical likelihood of disease using age, sex, symptoms, and this is why it's important to define symptoms as being cardiac or non-cardiac, and risk factors such as diabetes, hypertension, dyslipidemia, smoking, and prior evidence of atherosclerosis. And so testing is most helpful when the result can meaningfully change our probability of disease. And so I don't know if you've ever seen the graph of the Bayes' theorem. It looks like a football, and in very low likelihood patients, a positive test may be more likely to represent a false positive and may only move the post-test probability of disease slightly. And in general, diagnostic testing may be deferred in very low likelihood patients. On the other hand, in a very high likelihood patient, a negative test may not be sufficiently reassuring because post-test probability of disease may still be very high. So non-invasive testing in general is most helpful for diagnosing obstructive CAD in the intermediate range. And traditionally, this was described as about 15 to 85%, so a broad range. Although contemporary models generally estimate lower probabilities than older Diamond Forrester type models. I would keep 3 caveats in mind. First, most pretest probability models focus on obstructive epicardial CAD, and they don't fully capture ANOCA, INOCA, vasospasm, or coronary microvascular dysfunction. We'll talk about those later. Second, risk modifiers do matter: diabetes, prior chest radiation, known atherosclerosis, coronary artery calcification, and other clinical features may change our concern beyond just age, sex, and symptoms alone. And third, testing is not only about diagnosing obstructive CAD. In most patients, stress imaging, for example, can also provide risk stratification, ischemic burden, and CTCA can give us plaque burden, and other tests can provide myocardial blood flow. And all of this information risk stratifies and also helps to guide management.
Wow, this was a really, really good explanation about the importance and the critical value of the pretest probability when we are thinking about ordering a test of a patient who's coming for what we think it may be coronary disease. I really want to highlight that, as you mentioned, the probability of having the disease after the test is really impacted by the probability of the patient having the disease before the test. And for us, it's very important to dig deeper into the history and asking the patient about the symptoms to really get a sense of what's this risk before ordering any test. Now, before we decide on which imaging testing to order for Mr. Occlusion, let's pause for just a moment. In practice, when we see a patient like this in the clinic, we are not just choosing between two diagnostic tests. We are navigating a fairly extensive menu of available imaging modalities. And I think one of the most common struggles for providers is understanding the unique feature and uses of each available option. Can you provide an overview of the imaging modalities available for evaluating chronic coronary disease? What is the difference between functional and anatomical imaging? What is the goal of each category, and which modalities fall into each category?
These are all great questions, and I will try to summarize the different types of tests. We have many great tests, and they answer different questions. And that's why it's important to know the pretest likelihood of disease or probability and ask really, what is the clinical question we are trying to answer? And so then at the broadest level, I think of the imaging menu into two major categories: anatomic and functional testing. Anatomic testing tells us what the coronary arteries look like. That's a simplified version of this. The main non-invasive test in this category is the coronary CT angiography, or CCTA. It can tell us whether coronary atherosclerosis is present, whether it's obstructive epicardial coronary artery disease, and increasingly, it can also provide information about plaque burden and plaque characteristics, and maybe some of the functional significance of that as well, but we get into that later. The major strength of CCTA is its excellent negative predictive value. It's very helpful when we want to exclude obstructive CAD. And it has the added advantage of identifying non-obstructive plaque, which may also be very important for preventive therapy. The limitations are also important. Image quality can be affected by heavy coronary artery calcification, although newer technologies such as photon counting CT may help with this. High heart rates, arrhythmias, and cardiac motion can still be challenging for CCTA. CCTA also requires iodinated contrast and involves radiation exposure, although modern protocols have reduced radiation substantially. And finally, despite the increasing use of CCTA, it's not equally available everywhere. High-quality cardiac CT does require the right scanner technology, the right protocols, and expertise in acquisition and interpretation. I would also mention coronary artery calcium scoring here because it fits within the anatomic category. Calcium scoring is a simple, non-contrast, low radiation test, almost like getting a chest x-ray. But it doesn't define the coronary lumen. It does not tell us whether a lesion is flow limiting, but it can identify calcified coronary atherosclerosis and help refine risk. In selected lower risk patients with stable chest discomfort, the 2021 chest pain guidelines support CAC, coronary artery calcium scoring, as a reasonable option, so like a 2A, particularly when the goal is to refine risk and guide preventive therapy. We are also increasingly recognizing coronary calcium visually or opportunistically on non-gated chest CT or attenuation correction CT scans performed for other purposes. I think this will continue to expand, especially with AI approaches that can identify and quantify coronary calcium from scans that were not originally ordered for cardiac risk assessment. I have to admit that I don't usually use the coronary artery calcium score alone when the patient already has concerning symptoms or a higher clinical likelihood of CAD. In that setting, I need a test that answers the clinical question more directly of is there obstructive CAD, ischemia, impaired perfusion, or another cardiac explanation for the symptoms. And a high calcium score in this setting may confirm atherosclerosis, but I already suspected that in such a patient like Mr. Occlusion. And a low or even zero calcium score in this case doesn't necessarily explain the symptom or exclude non-calcified plaque or other causes of chest symptoms such as vasospasm, microvascular dysfunction, or something else. So, for symptomatic patients with intermediate to high likelihood, I usually would want either a CCTA to define the lumen and plaque or functional imaging to determine whether there is ischemia or impaired perfusion. And so this brings us to the other broad category, which is functional testing. And this asks whether coronary artery disease is causing ischemia or abnormal perfusion with stress. And the simplest functional test is the exercise ECG without any imaging. And it can still be useful when the patient can exercise adequately and has an interpretable baseline ECG. So no left bundle branch block or resting STT abnormalities, etc. And it is useful because it provides reproducible symptoms, exercise capacity, blood pressure response. Does the patient have arrhythmias? Are there ECG changes? And all of this is very important for risk assessment. But the exercise ECG alone has lower diagnostic accuracy than stress imaging, and it generally does not localize ischemia. And all of this is reflected in the 2021 chest pain guideline for intermediate to high-risk stable chest pain patients. Stress imaging or CCTA is generally favored for diagnosis, risk stratification, and management, whereas the exercise ECG without imaging remains reasonable, so a 2A as compared to a class 1 in selected patients who can exercise adequately and have an interpretable ECG. So when we need functional testing in a patient with intermediate to high pretest probability, we generally prefer stress imaging. And several stress imaging modalities are available. The 2021 chest pain guideline rates them all a class 1 in appropriate patients. But I have to say that these tests are not interchangeable. The best choice depends on patient characteristics, the clinical question, and local expertise. And so I'll break them down into just small bits here. So first, stress echocardiography evaluates inducible wall motion abnormalities and can also help assess non-ischemic contributors to symptoms, such as valvular disease, ventricular function, pulmonary pressures, or other structural abnormalities when image quality is adequate. So one thing to keep in mind about stress echo is that when there are significant resting regional wall motion abnormalities, the specificity of stress echo may be only modest. Stress SPECT or SPECT myocardial perfusion imaging evaluates relative myocardial perfusion, and it's widely available with extensive prognostic data. Now, PET myocardial perfusion imaging also evaluates perfusion, but adds higher image quality, routine attenuation correction, so really great for larger body habitus patients, and very importantly, it adds quantification of myocardial blood flow and flow reserve. And this is particularly helpful for multivessel disease or balance ischemia, more diffuse atherosclerosis, and also for coronary microvascular dysfunction. Stress CMR evaluates perfusion, function, scar, and other tissue characteristics, and can also help identify non ischemic causes of symptoms. So we have a lot of different options that are really great. Then we have to layer in patient specific considerations as we think about which test to perform. Echo and nuclear techniques generally do not require iodinated contrast, and so they're not limited by kidney function in the same way as CCTA. CMR, cardiac MRI, may require contrast depending on the protocol and on the type of contrast. Renal function may matter, but claustrophobia is usually more of an issue for cardiac MRI. Echo also depends on having appropriate acoustic windows. Nuclear imaging can be affected by attenuation artifacts, but again, PET with its robust attenuation correction helps substantially with this issue. Sometimes we also have to look at what medications patients are taking because most beta blockers and some calcium channel blockers are going to limit heart rate response to dobutamine for dobutamine stress echo, and vasodilator stress nuclear perfusion imaging may be preferred in those patients. And then lastly, unlike CCTA, image quality with stress imaging, especially with stress nuclear imaging, is going to be less affected by high heart rates, arrhythmias, or heavy calcification as compared to CCTA. These tests all have different properties and are all useful in the appropriate clinical scenario. They're all rated a class 1 by the Multi-Societal Chest Pain Guideline and Chronic CAD Guideline, again in appropriate patients. So I know that was a long answer, but I think we covered all the imaging modalities.
Thank you for walking us through the various imaging modalities so clearly, Dr. Chareonthaitawee. I love how you framed that around first defining the clinical question and considering both patient and modality-specific factors. The biggest takeaway for me is that no imaging test answers every single question. Anatomic imaging like CCTA tells us what the coronaries look like, while functional imaging like stress echo, PET, SPECT, or cardiac MR tell us whether that disease is actually causing ischemia. So rather than asking which test is best, we should ask which test is best for this patient at this time to answer this specific question. That's the essence of patient-centered imaging and why all of these modalities continue to play an important role in contemporary CAD evaluation. Now, for listeners who want to learn more about the evolving role of CCTA, CTFFR, and AI-based plaque analysis, be sure to check out CardioNerds episode 451 with Dr. Michael Gallagher. Now, with all of these tools available, Dr. Chareonthaitawee, which patient factors help you decide which one to use? Do you have any practical decision-making framework that you use? Is it algorithmic or more nuanced than that?
Yeah, I think this is more nuanced than a simple flowchart. I wish I could give you a simple flowchart, but I think getting back to the basics of starting with the clinical question is helpful. So if I want to know, does the patient have coronary atherosclerosis or obstructive epicardial CAD? I think here CCTA is often attractive, especially in patients with lower to intermediate clinical likelihood, no known CAD, acceptable renal function, and a heart rate and rhythm that allow good image quality. It also gives us information about non-obstructive plaque and plaque burden. But I think one practical point here is that CCTA does not always end the diagnostic pathway. I often see patients after CCTA shows moderate disease, and the clinician is still unsure what to do. And so at that point, the clinical question changes from is there plaque to is this disease physiologically important? Is it causing ischemia? How much myocardium is at risk? and does it explain the patient's symptoms? And so this is where we would then shift to functional testing or maybe even CT-derived FFR in selected patients, or sometimes invasive studies may be helpful or needed. If I have a higher risk patient and I want to know, is this disease causing ischemia or abnormal perfusion, then I often start with functional testing, particularly in patients with higher clinical likelihood, older patients, known CAD, prior revascularization, or when I need to define the extent, severity, and territory of ischemia. Again, I layer in patient factors. Can they exercise? Is the ECG interpretable? Are the echo windows good? Is there obesity, kidney disease, arrhythmias, heavy calcification, prior stenting, or prior bypass surgery? And PET may be especially helpful with obesity, attenuation artifacts, suspected diffuse or multivessel disease, and or suspected microvascular dysfunction. And stress echo is attractive when windows are good and I want to avoid radiation or contrast, or when there's not a lot of resting wall motion abnormalities. And stress CMR is helpful when I need perfusion, function, scar, and tissue characterization. So a lot of thinking when I'm seeing the patient and deciding which test to use. And so in addition to all that, we have to think about availability and expertise as well, because I usually don't want to wait, 3 weeks to have a test, or if the test is not performed usually in our center. So patient preference also matters. And so we do a lot of shared decision making. Patients may have concerns about radiation, contrast, exercise, claustrophobia, even cost, and they may have had a bad experience with some type of test. So I usually discuss the pros and cons and choose the test that answers the clinical question while also keeping in mind the patient's values and circumstances.
Thank you for that wonderful response. I think one of the themes of this episode is really emphasizing going back to the clinical question and using that as providers to help guide which test we order, specifically considering the patient's characteristics. Is this a higher risk patient or more of an intermediate risk patient? Looking at their comorbidities and including their renal function, their history, if they have any history of prior stenting, of prior CABG or revascularization. They have a past medical history that includes obesity, their exercise capabilities, thinking of the actual different imaging modalities and what they encompass. So for echocardiogram, for example, is this a patient where we would expect good echo windows? And then also considering the institution in which we practice. So the availability of different testing and the expertise of the different modalities is something that I don't think is discussed very often, but is very important to consider. So I thank you for that very thoughtful response. Now let's return to our case, Mr. Occlusion. So he is 58 years old. He has an intermediate pretest probability with angina that's most likely cardiac in origin, mildly elevated A1C and LDL cholesterol with a normal LP(a) and high sensitivity CRP. Recognizing there may be some institutional variability, again, based on the availability and the expertise, which imaging modality would you choose for him and why?
So for Mr. Occlusion, I would not think of his scenario as one mandatory first-line test. He is an intermediate likelihood patient with possible to probable cardiac symptoms. So both CCTA and functional imaging could be appropriate. CCTA would be very reasonable if the main question is, does he have coronary atherosclerosis or obstructive epicardial CAD? He has no known CAD, and if renal function, rhythm, and image quality are suitable and there is local expertise, CCTA would be able to define plaque, stenosis, and overall plaque burden. And it can be very helpful for diagnosis and prevention. So this may be nuanced though, but in the pre-specified PROMISE trial analysis, among patients with diabetes, those who had CCTA had a lower risk of cardiovascular death or MI compared with those randomized to stress testing. But it was a subgroup pre-specified analysis, not the main PROMISE result. So I wouldn't overstate it that as proof that all diabetics should have CCTA first. But the other thing is that CCTA may prompt more preventive and anti-ischemic therapy. But I think in Mr. Occlusion, who has chest pain that is most likely cardiac and he also has diabetes, he should receive therapy and risk factor modification regardless. I think if you look at the chest pain guideline, functional imaging would also be reasonable here, especially if the main question is, are his exertional symptoms due to ischemia and what's the extent and severity? And this becomes especially important when we're worried that anatomic findings may be moderate or uncertain, or when we need to know whether the disease is physiologic important. Depending on his exact body habitus, and also because he has diabetes, I may lean towards PET myocardial perfusion imaging with flow quantification over SPECT MPI or stress echo. But that is maybe more of my preference and also institutional expertise. I think fortunately we have institutional expertise in all three modalities. So I think with all things being equivalent, I might consider PET MPI as well in this patient.
Thank you. So CCTA has really revolutionized the field over the last decade. Could you walk us through the major clinical trials that helped establish CCTA's role in chronic coronary artery disease, specifically the PROMISE and the Scott-Hart trials?
Oh, of course. So I think one promise was a large multi-center randomized trial of stable symptomatic outpatients assigned to either an initial CCTA strategy or an initial functional test strategy. And functional testing included exercise ECG, stress echo, and predominantly stress SPECT. PET was not the nuclear comparator in PROMISE, so this is important as we think about applying findings to our current PET MPI practice. PROMISE is an important trial because it showed that an initial CCTA strategy is safe and clinically comparable to functional testing in stable symptomatic outpatients. But PROMISE did not show that CCTA was superior to functional testing for overall outcomes. In the main trial, outcomes such as death, ACS, and major procedural complications were similar. So, where CCTA may also add value is that it defines plaque, as mentioned before, including non-obstructive plaque, and this can lead to greater or more intensification of preventive therapy. There was also this interesting pre-specified diabetes analysis that I mentioned that suggested lower cardiovascular death or MI with CCTA compared to stress testing. And this is relevant for a patient like Mr. Occlusion. But again, I would be careful not to overgeneralize this because of his symptoms and diabetes and multiple CV risk factors, and the patient should already be receiving therapies and risk factor modification. Then the second trial we mentioned here, Scott-Hart, was another major trial with CCTA. It was also multi-center and randomized. It was in the United Kingdom and had patients with suspected stable angina who were assigned to standard care alone or standard care plus CCTA. And standard care at that time often included mostly the exercise ECG. So it was different from PROMISE. It's been pointed out that how patients were informed and treated in the trial was much different between the two arms, with the more preventive care perhaps being received in the CCTA arm. So the main finding was that adding CCTA improved diagnostic certainty and change management. And at 5 years, the CCTA strategy was associated with a lower rate of coronary heart disease death or non-fatal MI. So my interpretation is that Scott-Hart shows the value of identifying coronary atherosclerosis, including non-obstructive plaque, because that can lead to more appropriate preventive therapy. The benefit was likely not simply from revascularizing more patients, but from clarifying the diagnosis and intensifying medical therapy. So beyond simply asking whether there's an obstructive stenosis, CCTA can give us broader information about atherosclerotic burden and risk. It can, quantify overall plaque burden and characterize plaque features that may be associated with higher risks, such as low attenuation plaque, positive remodeling, spotty calcification, or napkin ring sign. And then for lesions of uncertain significance, CT-derived FFR now can add physiologic information in selected patients as well. So there's a lot of information now that you can get from CCTA, since the time of those trials. And so I think CCTA is increasingly not just an anatomic test, and it can provide us additional information, even physiologic information as well.
Definitely, CCTA scope has increased lately, and we're seeing promising studies that support its use as it grows as another tool in the arsenal for multimodality tools to evaluate chronic coronary disease, and very importantly, as a tool to refine diagnosis and optimize medical therapy. But the decision, as you mentioned, of which imaging to use is very nuanced and personalized, and surely cannot be generalized for all patients. Well, now let's move on to our second patient, Mr. Salicylate. He's a 45-year-old male with hypertension on lisinopril, dyslipidemia treated with lifestyle modifications, childhood Hodgkin lymphoma that received mantle radiation, and a 25-year smoking history who presents with exertional chest tightness over the past 2 months. He reports that despite the symptoms, he tries to keep himself active and walks flat with minor issues. But when he tries to go uphill or up the stairs, the symptoms become more severe and he has to stop. He describes his symptoms as if someone is sitting on his chest, as well as some jaw discomfort. Recent labs reveal an A1C of 6.3%, but his LDL cholesterol remains elevated at 152 despite his habit modifications. His blood pressure is 132/80, and we obtain a resting EKG in the office that is normal. The patient is distressed as he thinks the symptoms are related to the cancer history. Dr. Chareonthaitawee, is this case, how would you classify the patient risk profile and what modality would you think should be prioritized for this patient? What type of stress would you prefer and why?
So this is a very interesting case because as a fellow, I became very interested in radiation-induced heart disease. But in any case, I think this patient has several features that increase my concern. His symptoms are exertional and described as chest pressure with jaw discomfort. They occur with higher workloads such as hills or stairs, so he's not unstable. He also has hypertension, dyslipidemia, a smoking history, and importantly, prior mantle radiation. So I would consider him at least intermediate and probably intermediate to higher clinical likelihood patient. The prior radiation history is important because these patients can develop premature coronary disease, often involving proximal or ostial segments, but they can also have other radiation-associated cardiovascular disease, including valvular disease, pericardial disease, myocardial restrictive disease with restrictive physiology, and sometimes pulmonary hypertension due to bad lung disease from radiation injury. And so I think here in this patient, stress echo is attractive if he has adequate acoustic windows. It's widely available, it avoids additional radiation and avoids contrast. It can also assess more than just ischemia. We can look at resting and stress LV function, valves, pulmonary pressures when feasible, and other structural contributors to his symptoms, especially again with his prior radiation therapy. But I think with prior radiation and lung disease, this may also make his acoustic windows more challenging. And as we all know, stress echo can also be more operator and image quality dependent. But so if image quality is an issue at rest, it will be worse with stress, and other types of testing, such as stress nuclear or CCTA, may also have to be considered. So I think we have to start with the resting images and see where things stand. When patients can exercise adequately, and I'm not sure if this type of patient can, exercise is preferred over pharmacologic stress because it can provide a lot of useful additional information along with the images. So symptom reproduction is very important. And this patient says he's getting symptoms with exertion. Exercise capacity is always extremely prognostic. Blood pressure response, heart rhythm, and heart rate, and whether symptoms occur at high or low workload. So all of that information is often just as clinically useful as the imaging results. If pharmacologic stress echo is needed, we usually use dobutamine, but dobutamine should be avoided in patients with unstable symptoms, uncontrolled hypertension, significant arrhythmia, severe symptomatic aortic stenosis. So I think we have to see what the resting echo also shows, if there is also marked dynamic outflow obstruction, and really any situations where increasing heart rate and contractility can be unsafe. And importantly, dobutamine should not be combined with walking or treadmill exercise like we may do with vasodilator stress. So I think in this patient, stress echo can be considered as long as he has acceptable acoustic windows and he can either exercise, if he can exercise well enough, or we could do a dobutamine echo with or without atropine. So that would be possibly my top choice for this patient if he has adequate acoustic windows.
That was a truly fascinating case. I think for me, a big takeaway is if you have a patient with a history of prior radiation, to really consider whether the patient's current symptoms can be explained from ischemia or any structural abnormality, and therefore the potential role for a stress echo in a case like this. Again, considering the importance of looking at their resting echocardiogram windows and making sure that the image quality is adequate. Also considering in patients that are endorsing exertional symptoms, the importance of exercise testing or dobutamine echocardiography. Now, it is a busy day in the clinic, and the clinic is really giving us no break, so we're ready for our next patient. Our next patient is Mr. Coronary, and Mr. Coronary is a 67-year-old male with a history of hypertension, type 2 diabetes, dyslipidemia, CKD stage 3A with a GFR of 48, and obesity with a BMI of 38. He presents with a 4-month history of progressive exertional dyspnea, initially only with heavy exertion, but now has progressed to be present with mild to moderate exertion. He reports that he can walk only 1 block before symptoms develop, denies any chest pain, and reports only shortness of breath. He is a never smoker but has a strong family history of cardiac disease. Both his father and a brother had an MI before the age of 60. His LDL cholesterol is 118 on a moderate intensity statin. A1C is 8%, and an Lp(a) is within normal limits. His EKG shows a left bundle branch block, and his resting transthoracic echocardiogram was unremarkable. However, it was technically limited due to poor acoustic windows. So here we have a very different clinical picture. Mr. Coronary has a different risk profile with a family history, diabetes, obesity, hyperlipidemia. He also has CKD, which may limit our contrast use, obesity, which limits our echo windows, and a baseline left bundle branch block. Dr. Chareonthaitawee, how would you approach evaluating this patient, and which imaging modality should we consider?
So another great case. You're keeping me busy here. Another intermediate to higher likelihood patient and potentially a higher risk patient. He has several features that make CAD more likely, including diabetes, hypertension, dyslipidemia, obesity, and a strong family history, and progressive exertional dyspnea. So dyspnea can certainly be an anginal equivalent, especially in patients with diabetes. So he has several factors that affect test selection. The CKD makes me more cautious about iodinated contrast use, although a eGFR of 48 is not an absolute contraindication. Obesity and technically limited resting echo certainly raise concern for stress echo, and so I probably would stay away from that. The left bundle branch block makes the exercise ECG alone without imaging non-diagnostic for ischemia, and functionally the patient can only walk 1 block, so most likely will need a pharmacologic stress test. So in this case, I would favor a vasodilator stress nuclear perfusion study. Even if the patient could exercise, left bundle branch block can be associated with false positive septal and other perfusion defects during exercise in the absence of angiographic CAD, and this will reduce your test specificity. Vasodilator stress helps to mitigate this issue, and so we prefer to perform vasodilator stress in left bundle branch block in the nuclear lab, even if patients can exercise. And this could be a board's question, especially for the nuclear boards. So then the question becomes SPECT versus PET MPI. Of course, SPECT is widely available, well validated, and has an extensive prognostic evidence base, but the chest pain guideline, as well as the US and European chronic coronary syndrome guidelines, and the ASNC PET MPI position statement all increasingly support PET over SPECT when PET is available, because PET does offer higher image quality, routine attenuation correction, lower radiation exposure, fewer equivocal or non-diagnostic studies, and robust myocardial blood flow quantification and calculation of myocardial flow reserve. And the diagnostic and prognostic literature is also expanding rapidly for PET MPI. So the point that is particularly important in this patient is really the value proposition of PET, and that's the robust myocardial blood flow quantification. And in a patient with diabetes, obesity, CKD, and dyspnea, I'm not only worried about focal epicardial stenosis, I'm also thinking about diffuse atherosclerosis, multivessel disease, balance ischemia, and or microvascular dysfunction. And relative perfusion imaging alone can miss all of these things, such as balanced ischemia or diffuse reductions in flow, whereas absolute flow quantification with PET can help identify these patients and tell us if there is an impairment in flow in all different territories. So my answer here would be for this patient, stress nuclear perfusion imaging, and if you have high quality PET MPI, I would preferentially use vasodilator PET here with myocardial blood flow quantification.
Thank you, Dr. Chareonthaitawee. I think this case really highlights how patient characteristics often drive the test selection as much as the symptoms themselves. In this patient, like you very clearly explained, not only are we considering the left bundle branch block, the obesity, but the fact that the patient has diabetes and CKD raise concern for not only obstructive CAD, but also diffuse atherosclerosis and microvascular dysfunction. Therefore, we have to consider the key advantage of PET, that it goes beyond relative perfusion by allowing quantification of myocardial blood flow and myocardial flow reserve. So the takeaway is that in higher risk patients like this, the goal isn't simply to detect a stenosis, it is to understand the entire spectrum of coronary vascular disease. And PET can provide unique physiological information to help us do that. So I'd love to spend a little bit more time on PET imaging, since it's not as routinely used as SPECT, but has distinct properties that make it unique and provide valuable information. Dr. Chareonthaitawee, what is the unique value of PET stress? How important is quantifying myocardial blood flow, and how does this impact treatment decisions?
So thank you for this question, because this PET MPI is one of my favorite topics. It has several unique strengths: excellent image quality, routine and robust attenuation correction, fewer equivocal studies, and lower radiation exposure than conventional SPECT imaging. But the feature that really distinguishes PET is the reliable myocardial blood flow quantification, and that is the value proposition of PET myocardial perfusion imaging. So with PET, we can measure absolute myocardial blood flow at rest and again during stress. And then we calculate myocardial flow reserve. That's the ratio of stress to rest flow. And stress flow, absolute stress flow, tells us how well the coronary circulation can augment blood flow under stress. And a regional reduction in stress flow less than 1.8 may suggest severe epicardial stenosis. Myocardial flow reserve, again, this is stress flow divided by rest flow, or MFR. It reflects the integrated effect of epicardial stenosis, diffuse atherosclerosis, microvascular function, and hemodynamics, as well as the adequacy of stress. The threshold we generally use is 2, and MFR is also highly prognostic. And all of this matters because relative perfusion imaging, as I mentioned before, can underestimate diffuse disease or balance ischemia. If all territories are similarly underperfused, the relative perfusion images may look only mildly abnormal or even deceptively normal. And PET flow can then show us if there's globally reduced stress flow or flow reserve. And this is particularly helpful in patients with diabetes, CKD, obesity, dyspnea, multivessel disease, or suspected microvascular dysfunction. And in terms of treatment decisions, flow doesn't replace clinical judgment, but it can change the level of concern and help to guide the next step. Severely reduced regional flow may push us towards more anatomic or invasive evaluation. Globally reduced flow reserve may support diffuse CAD or more extensive CAD than what we're seeing with relative perfusion imaging alone, or it may support microvascular dysfunction, and it may lead to more aggressive risk factor modification and tailored anti-anginal therapy. Preserved perfusion and preserved flow and flow reserve are then also very reassuring on the other hand. Now, some programs or software provide coronary flow capacity, and this integrates stress flow and flow reserve into categories of preserved, mildly, moderately, or severely reduced. And it's another promising way to grade physiologic severity. And there have been a few trials, like the Century trial, that are exploring flow guided management. But in practice, I still interpret PET flow together with the perfusion data and the symptoms, LV function, ECG findings, and coronary anatomy in the form of coronary artery calcification from the low dose non contrast CT. So integrating everything helps to make management decisions. And I have to also mention that PET is becoming more and more routine. And nearly every week, lab directors from all over the country contact me asking me how to start a PET MPI program or whether they can visit our lab. So it's moving from a more sort of niche test to having a more central role in chronic coronary disease, especially when quantitative flow can change the clinical interpretation.
That was certainly fantastic, Dr. Chareonthaitawee. Definitely, PET perfusion is becoming more and more used and available as a very valuable tool for evaluation of chronic coronary disease due to its unique properties. Particularly, I want to highlight the blood flow quantification and overall evaluation of epicardial stenosis, diffuse atherosclerosis, and microvascular dysfunction, all integrated into one only test. We have a very busy clinic day, and another patient is waiting for us. Mr. Plaque is a 64-year-old man with a history of acute coronary syndrome that is post-PCI to the mid-LAD and left circumflex. He was doing well until 3 months ago when he began experiencing recurrent exertional chest pressure similar in characteristic to the prior symptoms before the acute coronary syndrome. He has a history of hypertension and hyperlipidemia, and he's a former smoker. He reports being compliant to all his medications, including aspirin, valsartan, rosuvastatin, and ezetimibe. His EKG shows ST changes in lateral leads that are unchanged from prior EKGs. His primary care doctor ordered a coronary CTA, which was reported as non-diagnostic due to extensive calcification, and they referred him for angina. This scenario is not uncommon. Mr. Plaque is a post-revascularization patient with recurrent symptoms, and his CCTA was unhelpful. Dr. Chareonthaitawee, how would you use non-invasive imaging to further evaluate this patient's symptoms post-revascularization?
Yeah, you're keeping me really busy. We have Another great, very common scenario, and in a patient with a known CAD and prior PCI, for example, the question is no longer, does he have coronary disease? We know he does. The question becomes, are his recurrent symptoms due to inducible ischemia? Where is it? How extensive is it? And does it correspond to a territory that may need further evaluation? So CCTA can be useful in selected post-revascularization patients, particularly for bypass grafts or larger, well-visualized stents. But after PCI, CCTA can be limited by stent artifact, small stent size, cardiac motion, and heavy calcification. In this case, the CCTA was already non-diagnostic because of heavy calcification. So I would move to functional imaging. And so here, I think we're looking for the presence, the territory, and severity of ischemia and assessment of LV function and high-risk features. And again, if PET is available, PET can be very attractive because of image quality, attenuation correction, and myocardial blood flow quantification, which can help identify diffuse or multivessel disease. If PET is not available, stress spect or stress echo could also be performed. That said, though, if the patient has unstable symptoms, rest symptoms, rapidly progressive angina, heart failure, high-risk ECG changes, or symptoms despite really good medical therapy with high suspicion for severe disease, I would not delay with more non-invasive testing and I would proceed to invasive coronary angiography. But again, shared decision-making is very important here.
That was truly a great case and definitely one that we very often see in clinic and in the hospital when we have patients with known CAD, history of a prior PCI. And I think it's important to consider now switching the clinical question to trying to understand if his current symptoms are due to the ischemia and the potential role of functional imaging in a case like this, as well as the consideration of potentially just going straight to the invasive testing. Now, we have one less patient in clinic who was added to our schedule for concerns of angina. Our last patient is Mrs. Calcium, a 52-year-old woman who was referred to the CAD clinic after a 6-month history of exertional dyspnea and chest pain described as pressure-like, radiating to the jaw. Currently, she says she can walk only 1 block before her symptoms occur. She has a history of hypertension on amlodipine, hyperlipidemia on atorvastatin with the most recent LDL cholesterol of 102, and migraines. She was worked up by her PCP with a CCTA, which showed no obstructive coronary artery disease, all vessels less than 20% stenosis, with mild non-calcified plaque. Her symptoms, however, have not resolved. She was told that her heart is quote-unquote normal, but she remains symptomatic and feels dismissed. I feel that this scenario is very common and honestly one that I think reflects a historical gap in how we evaluated and often dismissed patients with persistent angina and non-obstructive coronaries. Dr. Chareonthaitawee, what is INOCA? When should we consider it? And what role does non-invasive imaging play in cases like Mrs. Calcium's?
So you're absolutely right. I work in the complex chest pain and coronary physiology clinic here where I see this type of patient, and they often have a very long journey of undergoing multiple types of tests and not having a diagnosis, and they often feel very dismissed, and it really affects them, and they often become, very depressed. And so I think INOCA is very important. The pathophysiology is important. And the coronary circulation is not just the large epicardial vessels that we see on angiography or CCTA. The microvasculature is responsible for regulating myocardial blood flow, especially during stress. And patients can have coronary microvascular dysfunction, endothelial dysfunction, impaired vasodilator reserve, or vasospasm. So even if there is no severe focal stenosis, the coronary circulation may still fail to augment flow appropriately at various times, and sometimes most often during mental stress. And so that is INOCA, is ischemia without obstructive coronary arteries. So in this patient, the symptoms are exertional, pressure-like, and radiate to the jaw. She can only walk 1 block. I would not dismiss this as normal. And just because the CCTA showed less than 20% stenosis, mild non-calcified plaque also tells us that she has some coronary atherosclerosis, even if it's not obstructive. So non-invasive imaging can help in several ways. Here we use stress PET a lot in these patients because of the myocardial blood flow quantification. This can show whether there are global or regional stress flow reductions or abnormalities in myocardial flow reserve. And in the absence of severe epicardial disease, and in the presence of abnormalities in flow or flow reserve, the problem is then most likely at the microvascular level. This can also be shown with stress CMR, although I find that we are probably performing far fewer stress CMRs here as compared to stress PET. Stress echo or stress spec may identify ischemia, but conventional relative perfusion imaging or wall motion imaging can be normal in microvascular dysfunction, especially if the abnormality is kind of diffuse rather than regional. This is more important than for nuclear imaging. If non-invasive testing suggests impaired coronary vascular function, that can help validate the diagnosis of INOCA and guide therapy. And if symptoms remain severe despite non-invasive evaluation and treatment, invasive coronary function testing can be very helpful to define the endotype of disease. Is it microvascular dysfunction, epicardial vasospasm, microvascular spasm, or a combination of all of the above? So I think the practical message is that INOCA is real. A normal or near normal CCTA shouldn't always end the evaluation. But I often get this question, what's the point of making the diagnosis if there's no definitive treatment? So my answer to this is that for many patients, they have been sort of given the runaround for maybe a year and going around visiting many ERs, seeing many doctors without a diagnosis, and they continue to have symptoms. So just getting the diagnosis and getting the diagnosis right is 90% of it is a huge part of how they feel. And so it helps to validate what they're feeling and being able to say, hey, your symptoms are real. They may reflect abnormal coronary vascular function. This is incredibly important. The diagnosis also matters because INOCA is not just one disease. There are different endotypes, as I mentioned, and the treatment approach may differ depending on the mechanism. And this was one of the important lessons that we learned from the only randomized trial in this space, the CORMICA trial, that when invasive coronary function testing was used to identify the endotype and to guide therapy, patients had improvement in angina and quality of life compared with usual care. So diagnosis can directly change management. And really, the treatment landscape for INOCA is evolving. Depending on the mechanism, we may use anti-anginal therapy, calcium channel blockers, beta blockers, nitrates, ranolazine, or ACE inhibitors or ARBs, statins, aggressive risk factor modification, exercise training, and the treatment of associated cardiometabolic disease. There are emerging approaches and trials, including therapies directed at microvascular dysfunction, vasospasm, and cardiometabolic pathways such as SGLT2 inhibitors in appropriate patients. We even have device-based approaches such as coronary sinus reducers in selected refractory angina populations as well. So I think the goal is not simply to label the patient or give a diagnosis, but really it helps to validate symptoms, define the mechanism when possible, tailor therapy, and avoid the cycle of repeated non-diagnostic testing and multiple ER visits, and really help identify patients who may be eligible for more targeted or emerging therapies.
I love that perspective because I think it's one of the most important lessons for us and our listeners. The takeaway is that a normal angiogram doesn't always mean a normal heart. INOCA is common, especially in women, and many patients have real ischemic symptoms despite the absence of epicardial obstructive coronary disease. As you clearly highlighted, the problem may lie in the microvasculature, or coronary vasomotor function, which is why advanced imaging techniques like PET can also be so valuable in selected patients. And perhaps most importantly, making the diagnosis matters. It validates patient symptoms, helps us understand the underlying mechanisms, and opens the door to more personalized treatment rather than simply telling the patient that everything is normal. Wow, this has been absolutely amazing. You've beautifully walked us through the current landscape of non invasive evaluation of coronary artery disease. After today, I surely feel more confident in caring for patients presenting with chest pain in my practice. It is also clear that this is a constantly evolving field. As you exemplified with recent developments and evidence regarding CCTA and functional testing. Before we wrap up our conversation, we would love to ask you what excites you the most about where non invasive evaluation of chronic coronary disease is heading, and where do you see the field heading in general?
Well, that's a really great question. I think what excites me most is that we're moving beyond the simple question of is there a severe epicardial stenosis or not? And chronic coronary disease is much more complex than that. We're increasingly able to assess plaque burden, plaque characteristics. It's not only ischemia, but also myocardial blood flow, microvascular dysfunction, scar, and overall risk. So I think the future is about integrating all of this information, anatomy and physiology, and much more. And CCTA can tell us about plaque and stenosis, and PET and other quantitative approaches can measure myocardial blood flow and coronary vascular function. And stress echo, stress CMR provides a lot of really great information about function, structure, tissue characteristics, and other cause of symptoms. And all these tests are not really competitors, they're complementary tools that help us to answer different clinical questions. And so at the same time, I have to say that I'm very excited about the growth of cardiac PET with new perfusion tracers, new scanner systems, and greater interest from programs that historically didn't have PET. And these advances may make high quality perfusion imaging and myocardial blood flow quantification more accessible to more patients. I'm also excited about more personalized imaging, choosing the right test for the right patient, reducing non diagnostic test results, and using quantitative data and also eventually AI to help integrate all of the data and guide decisions more thoughtfully. And I think importantly, the field is finally paying more attention to patients with ANOCA, microvascular dysfunction, and diffuse disease, patients who were often told that their tests were normal despite ongoing symptoms. And so I think all in all, the field is moving really towards more integrated, quantitative, patient centered imaging that combines all of the things we've discussed to help us make better decisions for individual patients.
I agree with you. I think that speaking for myself, but I feel that also some of the listeners will feel the same. We're looking forward to all these new techniques, findings, and especially properties and features from the imaging tools that you mentioned in order to provide a more personalized care of these patients that ultimately what we want to do is reduce the burden of morbidity and mortality and this disease. Dr. Chareonthaitawee, we have covered an enormous amount of ground today, from defining CAD and classifying chest pain to building a personalized imaging strategy for 4 very different patients. I definitely learned a ton today and will have a better, more practical approach when seeing patients with suspected angina or any other symptoms that made me think about coronary disease. If you were to summarize our conversation with some take-home messages for the audience, what would they be?
So I would summarize the conversation with a few key points. First, I would start with the clinical question. Before ordering any tests, ask, what am I trying to learn? And what will the result change management? What's the pretest likelihood of disease? Second, chronic coronary disease is not just obstructive epicardial stenosis. It includes non-obstructive plaque burden, ischemia, diffuse atherosclerosis, microvascular dysfunction, vasospasm, and other symptoms, and also risk. And third, anatomy and physiology are complementary. CCTA is excellent when we want to define anatomy, plaque, and stenosis. Functional imaging is critical when we need to know whether disease is causing ischemia, how much myocardium is involved, and whether findings explain the patient's symptoms. Fourth, patient factors matter. Think about exercise capacity, the baseline ECG, the body habitus, kidney function. Does the patient have arrhythmias? Was there prior PCI or CABG? And local expertise all influence the best test. There is no single best test for every single patient. And fifth, when nuclear perfusion imaging is selected and PET is available, PET is preferred because it offers important advantages: better image quality, more robust attenuation correction, fewer non-diagnostic studies, lower radiation, and reliable myocardial blood flow quantification. And finally, we should not dismiss persistent symptoms just because there's no obstructive CAD, because INOCA and coronary microvascular dysfunction are real, they're clinically important, and increasingly diagnosable and treatable. So I think the overarching message is choose the right test for the right patient, interpret the result in the clinical context, and use imaging to guide care, not just to generate another test result.
Thank you so much for such a great summary and take-home message. I think those are all really great points. The audience and myself really find them tremendously relevant and helpful for our practice. Before we let you go, we have one final tradition on CardioNerds. We would like to know what makes your heart flutter about the field of imaging and chronic coronary artery disease.
Oh, I hope my heart doesn't flutter, but what is exciting is that cardiac imaging sits at the intersection of physiology, technology, and patient care. And we're not just looking at pictures, we're trying to understand why a patient feels the way they do, what's happening at the coronary circulation, and how we can use that information to make better decisions. And in chronic coronary disease, I think that's especially powerful because the disease is so heterogeneous. One patient may need look at the anatomy, another may need ischemia assessment, another needs flow quantification, and somebody else needs someone to recognize that non-obstructive coronaries does not mean non-cardiac symptoms. I also love that the field keeps moving, and each of the modalities I mentioned really have had advances within their field. And for PET, it's new tracers, new scanner, eventually AI, but in other areas also more precise and more personalized ways of evaluating patients. And ultimately, what's really important is that imaging helps the patient. When it gives an explanation or reassures appropriately, identifies risk, guides therapy, or validates symptoms that have been dismissed. And that's what makes this field so meaningful to me. So really, thank you for having me here today. It's been a great pleasure.
Dr. Chareonthaitawee, on behalf of the entire CardioNerds team, thank you so much for joining us and sharing your expertise and passion with us. This has been an absolutely incredible deep dive into non-invasive evaluation of chronic coronary disease. And to all of our listeners, thank you for spending this time with us. Be sure to check out our show notes and references for this episode, as well as the accompanying review article on multimodality imaging and chronic coronary disease in US Cardiology Review.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Iman Razeghian. I'm an intern in the CardioNerds Academy and a medical student at Shaib Beheshti University of Medical Sciences. Check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us to spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.